housekeeping. Well, welcome everyone. Thank you so much for being here today for this Learning Community Collaborative. In the meantime, while we're waiting to get started, if you just want to put your name, school-based health center, and role in the chat box, that would be great, just so we can see who's here. A couple of quick housekeeping items today before we get started. Just so you all know, my name is Gianna Calabrese, and I'm a program coordinator with Peer Assistance Services. I'll be helping monitor the session today. And just so you all know, today's session will be recorded. It'd be great if you could just, stay on mute for now. And if you have any questions throughout the training, feel free to put them in the chat box. And then for the last 15 minutes, Dr. Riggs will try her best to answer your questions. And then at the end of today's session, we will administer a post survey if you could just take a quick evaluation. So before we get started, I'll do a quick introduction of Dr. Riggs, who we're super excited to have present today. So Dr. Paula Riggs is a professor and vice chair of faculty affairs in the Department of Psychiatry at the University of Colorado School of Medicine. And as the director of the Division of Substance Dependence, she conducts and oversees a broad range of NIH-funded addiction research projects conducted by the division research faculty. She also provides administrative oversight for a large number of community-based adult and adolescent addiction treatment programs, collectively known as ART, or the Addiction Research and Treatment Services. Dr. Riggs is nationally known for her research and clinical expertise in adolescents with co-occurring psychiatric and substance use disorders. And this research informed the development of Encompass, which is one of the first truly integrated evidence-based mental health and substance treatment interventions for adolescents and young adults. So I will turn it over to you, Dr. Riggs. Like I said, we are so excited to have you here today.
Thanks for the invitation. Remind me, I thought I sent you a shorter bio. Oy vey, that was way too long. So anyway, hi guys, I'm glad to be here. Hope to be able to answer your questions, and I hope this will hit a sweet spot for you in terms of some additional clinical tools that you might use, seeing the kids in schools who are using or have substance use disorders, or tools that'll make brief interventions perhaps more effective. So I've entitled this as "Let's Aspire to Make SBIRT Work Even Better." You'll understand what the acronym ASPIRE refers to in a minute, but I want to give you some real practical clinical tools and tips for more effective brief interventions and treatment referral. The ERT part of SBIRT is the part that's kind of gnarly and difficult to make it work. So disclosures first, though, I've developed an executive director of Encompass, the integrated treatment program that Gina mentioned, and I also have research grant funding from the National Institute on Drug Abuse. And so at the end of the presentation, what I wanted, the take-home thing is I'd really like you to learn and actually apply and use clinical tools to enhance and evaluate the effectiveness of brief interventions, and be able to use, feel confident that you can use DSM-5 diagnostic criteria, and also something that we use often, and the National Institute on Drug Abuse has said is really one of the most valid measures, outcome measures for measuring, severity and frequency of substance use, which is a calendar-based timeline follow back, just so that you're facile and you feel like you're confident in determining what's the severity of substance use or substance use disorders in the kids you see, and so that you can know, at what point, where's the line? When should I refer to subspecialty substance treatment, and when is that clinically indicated? And then I really want to focus on clinical approaches so that, SBIRT SAMHSA used to talk about the warm handoff. Now they talk about a hot handoff. They don't specify what that is, but I want to talk about how you might do a hot handoff, and to make the likelihood of referred kids to actually engage in substance treatment if you do a referral. So kind of those are the goals, and let's hope we hit the mark. A little background, I know that you guys have all had lots of training and education in cannabis use and addiction and adolescent with adolescent focus too, but just as make sure we're on the same page. You know, both addiction and mental illness, they're largely pediatric onset. And so it's really, we're on the front lines of being able to early to screen and identify substance use disorders and co-occurring psychiatric disorders that often travel with. We are in the position of identifying early risk factors, those who are experimenting and may be at risk for progressing to more serious substance involvement, and those who have substance disorders. And the earlier we intervene, the better it is, and we can help prevent that chronic progression into adult chronic addiction that we all see, and it really takes its toll on so many lives. So we know that 50% of all psychiatric disorders start before the age of 15. Commonly depression, ADHD, oppositional defiant disorder, anxiety disorders, trauma, PTSD, and then 75% start before the age of 24. So again, pediatric onset, and we know the same is true for individuals, adults who suffer from chronic addiction. Most of them started using when they were in high school, teenage years. So, that's our job, is to stop this scourge. And most of the childhood onset psychiatric disorders or mental health problems actually increase the risk of developing an adolescent onset substance use disorder. So they travel together. One increases the risk for the other. And once the kids start using regularly, cannabis, alcohol, whatever, that it further either exacerbates or makes it more complicated to manage the pre-existing psychiatric disorders. And even if they don't have pre-existing, it increases the risk of developing psychiatric disorders and other mental health problems later. So it's important to know that, because the kids have both together. They travel commonly together. And the problem is, of course, why is it pediatric onset? Why do so many substance disorders, psychiatric disorders arise during adolescence? And that's because the brain's a moving target. It's undergoing rapid brain development from about age 10 into your mid-20s, 25. Your brain's under construction. And what's mostly happening is that, in kids, the ventral tegmentum, the central deep structures in your brain, or the reward center, it's not hooked up to the prefrontal cortex, and the prefrontal cortex is not hooked up to that ventral tegmentum or the reward center. But in adolescence, this starts myelinating first. So, this is kind of your, I don't know, sex, drugs, and rock and roll area of your brain. Let's do it, and that's why adolescents are a little bit more risk takers than adults. And if you want to wrap your head around this, think of yourself at age 15, think of yourself at age 25. And pretty much the difference between you at 15 and you at 25 is what myelinating or hooking up the prefrontal cortex to the reward center did for you. Less risky. And that takes from age 10 to mid-20s to wire this up. So, and drugs interfere with that process. And while the brain, mostly what's happening is this synaptic pruning, where, you're refining circuits. You're kind of like getting rid of some circuits that aren't used or aren't efficient, and you're preserving those that are used more frequently. It's not as simple as use it or lose it, but if you will, I'll tell you, it's sort of like, hey, do you think we're going to use these circuits for piano lessons or physics problems? Nah, we haven't used them so far. So, okay, I'm going to prune these. It's not that simple, but it's ish like that. And so the important take home point here is that what the predominant activities that adolescents are involved in during this rapid period of brain development matters, because it shapes the synaptic pruning, and it shapes the way the brain forms for a long time, maybe forever. There's still a lot of neuroplasticity into adulthood, no doubt, but that's why there's so many moving parts. They're vulnerable to mental illness and substance use during adolescence, and they're also vulnerable to experiment with whatever comes along, because this is hooked up, but this is not hooked up. So substance abuse during adolescence interferes with brain development and increases the risk of chronic addiction and chronic mental health problems. it's critically important when you see kids on the front end like this to be able to make sure that you are giving credible, research-based or scientifically valid information or psychoeducation to them about drugs. You guys are too young to remember the old Reagan era when they actually had the fried egg and they said, this is your brain on drugs. Like that is just not street cred, right? You've got to know what you're talking about. And so some of you may be very facile in this and really know, but you have to be able to tell kids the truth that is grounded in the most current science. And there's an easy way to do that. That is the NIDA website and some of the materials I distributed prior to this Learning Collaborative today will come to you. And that is, look, there's a great little booklet free. You can print them off and have them hang out in your office. I mean, they can pick them up. Marijuana Facts for Teens. It's totally research based. It's the current thing. And it's all the questions that teens ask. Hey, is marijuana really addictive? What are the short-term, effects? What are the effects on my health? What are the effects, long-term effects? But it's, it really goes through it. There's also a similar one, Marijuana Facts Parents Need to Know. And it gives information to parents. This is translated into Spanish, and I believe they've got other languages as well. So these are really important resources. And if you go on the website, NIDA website, www.drugabuse.gov, you can find, if you don't know, like, what are they talking about? What are these concentrates, or what are the dabs? What's the difference between a dab, a wax, a butane hash oil? What's the difference? You can find out. There's a little bulleted one pager for you, and it shows you pictures of them. So you can educate yourself in a very quick way around what are the effects, because, and I'm focusing on cannabis here because that is what all of your kids are using, right? I mean, yes, alcohol, yes, some other things that they're dabbling in, but mostly it's marijuana, alcohol, and it's marijuana that really catches them that they're using every day. And then it's also nicotine vaping. But most of the kids in Colorado and elsewhere in the country, the emerging research shows that most kids are not just vaping nicotine. They are co-using vaping cannabis and nicotine together, often in the same kind of vape device. So if you get somebody who's vaping nicotine, you've got to evaluate for cannabis. And you all know probably that the impact of cannabis on the adolescent brain development causes persistent neurocognitive deficits. Kids who are using, not even, you don't have to use daily, regularly, like several times per week, but not necessarily daily, causes persistent neurocognitive deficits. So such that starting before the age of 17, and the younger is the worst, 14, 15, 16, even worse, but before age 17, regular cannabis use, even if they stop at age 21, those neurocognitive deficits are still there at age 25. And that's not true for people who start in adulthood. Most of the deficits that they have from cannabis would resolve in a month or two. Not so for teens. And we don't know if they fully reverse even with abstinence yet. That the research is still out. But studies have shown significant reductions in adult IQ that may not be fully reversible even with abstinence. We're talking about 6 to 8 points adult IQ on average. That's a big hit. I mean, that's the difference between, yeah, I went to college, I didn't go to college for a lot of kids, or I went to business school, or I didn't go to business school for a lot of kids. This is really significant. I can tell you that the neurocognitive and IQ deficits are on par with lead poisoning, with environmental lead exposure in childhood. They give you an average of about 7.2, 7.4 point reduction in IQ. So it's everywhere in this country. In my mind, it's a public health crisis. It also at least quadruples the risk of first onset psychosis. Whether you have a risk for schizophrenia in your family history of schizophrenia or not, it can increase your risk of psychosis. We're seeing lots more presentations in the ED, emergency department, and inpatient psychiatric hospitalizations for first onset psychosis that seems to be cannabis precipitated or cannabis induced. And there is a clear relationship between suicidality and cannabis use and anxiety disorders. Kids who regularly use, even if they don't have an anxiety disorder, it increases the chance, at least doubles the chance of having depression, anxiety in young adulthood. So many of your kids will tell you, yeah, I started using it to chill out or to prevent my anxiety or to alleviate my anxiety. But after a while, it makes it worse for most kids. And so you kind of need to be on to this. Paranoia is very common. And this is no joke. Regular use of marijuana, especially the potencies we're seeing in Colorado and other legalized environments, is all this, the kids just like kind of stop caring about anything. They drop out of football, they drop out of activities they used to enjoy. Their life becomes constricted into a smaller and smaller box where it's preoccupation with the drugs, using drugs, recovering from the effects of drugs. And that's kind of life. And grades start going south. The other thing we see quite a bit is, of course, we see cannabis-induced hyperemesis, where kids, they vomit a lot and they cannot stop vomiting. I've seen 3 kids in the past 2 months who were hospitalized for severe dehydration due to cannabis-induced hyperemesis. So you just make sure that you know the facts when you're giving psychoeducation to kids around the risks of cannabis use. And the potency has gone through the roof. I'm sure you're aware of this, but back in the 60s, the average joint had smoked flower had 3% THC, and that went up a little bit in early 2000s, 4 to 6%. In the legalized environment, and it's gotten worse. It's gotten more potent since the end of 2016. The average joint in Colorado has about 25% THC, and that's just smoked flower. That's like, you couldn't even get anything that potent way back when in my day. The concerning thing, though, is how many kids are using concentrates. And these concentrates, shatter, wax, dabs, butane hash oil, are in the range of 70 to 90 or even higher percent THC. And that's such a super physiologic dose that we know certain things about it. The higher the potency, the more addictive it is. The higher the potency, the greater the risk of psychosis. The higher the potency, the greater risk of hyperemesis syndrome and all the other, and the neurocognitive stuff. So really dangerous. The trend, though, we haven't seen a big bump in the prevalence of adolescent cannabis use, but we were already very high, right? So at least 25% of high school seniors are using at least once a month, and 40% of those are using multiple times per week. So the problem is about 25% now of the market share of cannabis sales, marketing products, are these concentrates. So what's the concerning trend is maybe we're not seeing more, but more kids are using these highly potent THC. And that makes it more addictive. Even with lower potency stuff, we knew that 1 out of 6 adolescents who experiment with it will progress to become dependent or addicted to it, versus like 1 out of 11 adults. So the potency is related to abuse, liability, and addiction. And those who use daily have a 50 times greater risk of psychosis than non-daily users. So, and yes, marijuana is addictive, and unequivocal evidence that shows it's addictive. So the tips and tools to enhance the effectiveness of brief interventions and also referral to treatment when clinically indicated. So I want to go through a little bit of this. That is the DSM criteria and how you might use that to give personal feedback to kids. And also want to kind of walk you through a calendar-based timeline follow back. And apologies if some of these tools are familiar to you, but I think putting these tools in your kind of clinical, tool bag will really be helpful, and you'll figure out ways that you can apply them in the way you approach brief interventions. Personal rulers for their, how important it, well, we'll go through it, and personal feedback reports. That's been shown to be very important. Goal setting. And this is a pretty sophisticated tool. We don't do this in our treatment until about module 3, about 3 or 4 sessions in, a functional analysis, but it is the gold of treatment. And as I understand it, you guys, having been trained, multiply trained in SBIRT protocols and brief intervention, now you're kind of You know, it used to be brief intervention was one, maybe two sessions with a clinician, but I understand that you do sometimes longer brief interventions and also multiple brief interventions. And so you need more tools. What are you going to be doing? You don't want to just do the same thing over and over again. So you might want to use a functional analysis that really gets into the weeds of examining what is this kid's triggers, his internal triggers and external triggers for use. So let me just kind of walk through some of that. And another tip for successful brief interventions is the way I teach pediatricians or primary care clinicians to, or mental health, outpatient behavioral health clinicians to do this is that, look, if you're going to try a brief intervention for somebody, let's say, who probably meets criteria for a mild to a moderate substance use disorder, you know, you kind of, you want to kind of make that contract with them. Well, why don't you give this a shot? You know, for 2 weeks, you want to give it a shot to quit altogether. It's like, well, I could do that. Sure, I could totally do that. And, you know, to show that they're in control of their cannabis or alcohol use. But on the front end, it's better if you say, so, but let's just say right now, is this fair to say, you know, if it turns out to be harder, whatever the contract is that you set up in your brief intervention, you know, if it's harder to quit or cut down or achieve those substance goals that you set, then we can appreciate right now. Then you think, could we agree that if you haven't been able to quit, cut down, or achieve that goal, when we follow up with each other in a week, 2 weeks, a month, whatever period of time it is, could we agree right now that that will tell us something? And would you agree right now? We say, would you be willing to talk to somebody who has more expertise in this field for a brief consultation or evaluation if it's harder than we think? So on the front end, remember our agreement so that if they can't achieve it, they've already agreed to, we need to step it up a little bit. I like that approach as opposed to, well, what if they don't achieve it? Then you haven't set anything up. What are you going to do next if they didn't achieve the goal? So here's the timeline follow back. We use this routinely and throughout treatment, at pre-treatment and throughout treatment. And it's really an important tool for you guys, I think. And it's not that tough to do. For example, when I initially evaluate a kid who's come in for an eval for substance use, I will take out, I really take out a real calendar. And sorry, this is kind of blurry, but so if this is today's date, okay, so you're seeing the kid for the first time here, you want to get a sense of what they've been using and the frequency of use in the past 28 days so that you have some marker, understanding of what their severity and frequency of use and what they're using and what's their pattern of use at baseline before you do your brief intervention or treatment. And then you want to track, does it change in response to your brief intervention? I mean, we owe it to kids, if we're going to do any kind of intervention, to measure whether they're responding to the intervention we're providing. And if we won't know that if we don't measure it. So one tool that we use frequently is, all right, if today is the day I'm seeing the kid, I will count off 28 days, back to 28 days, and I'm going to go with the kid. So let's just do this together. And I will populate the calendar with memory prompts like, okay, oh, your birthday was the 15th of January. Okay, great. Birthday. This was a school holiday. All right. And this was, okay, this was New Year's Eve. All right. So put the relevant memory prompts on there. And then you go back and starting with yesterday, because today's not done yet. Starting with yesterday, it's like, all right, so you already know kind of what has the kid used in the past month. What is he currently using? Let's just say it's alcohol and it's marijuana. Okay, so yesterday. Now, the minimum that you want to put on the calendar is marijuana, yes or no, yesterday. Alcohol, yes or no, yesterday, if those are the two drugs they use. If you want to like get a better sense, it's marijuana, yes, no, yes. Okay, how many times? Frequency of use during the day, morning, you know, noon, after school, before bed, because I know you see this. And alcohol. Now I don't drink during the week, but I smoke weed every day. So yesterday, marijuana, yes, 4 times vaped, whatever. And then alcohol, no. Marijuana, yeah. And these kids, you might say, the kid's going to say, I don't remember Thursday 2 weeks ago. They don't remember, but they know their pattern. If they are daily users, I can tell you for sure they know when they didn't have it. They know. You can assume if they're a daily user, unless they tell you they couldn't have it, they didn't have it, they were pretty miserable, they used that day. They may not remember, was it 3 times, was it 5 times, but they will remember if they used or didn't use. So you just keep marching back. And so this was Sunday, all right, and this was Saturday, last Saturday. If they have a pattern of drinking on Friday night or Saturday and getting drunk, so alcohol, yes, on Saturday, no. And then they don't drink during the week, marijuana Friday, yeah, yep. And you can get either yes, no, or frequency and amount each of these days. Okay, Sunday, and here's Saturday again. Yeah, oh yeah, every weekend I go out with my friends and get drunk. So you march back and fill out the calendar with the kid. And just doing this exercise, you're both looking at it together, and it's like the kid's going, oh, well, I mean, I have kids all the time says, I guess I do use a lot. I mean, it really impresses them that every single day is marked with, I use some every day, often multiple times per day. I would encourage you to use a timeline follow back. And then what do you do with it? So that's their pattern of use coming in. Let's say you do a brief intervention and they have a goal of cutting down their use. Okay, I'm still going to use every day, but only once a day, or I'm going to try to only use on the weekends now. Okay, they might set that goal. So let's say you march back out. All right, so here's the day you saw them, and you're going to see them, I don't know, February 5th is the next time you're going to see them. February 5th. So you want to say you have another calendar with February back through the day you saw them last. And that is, so how to go this week? You check in with, okay. I was able to use on the week. I did slip up, and 2 days during the week I did use. All right, well, let's look at that. Yesterday, what'd you use? Marijuana? Yes, no. Alcohol? Yes, no. And you can get frequency. So what you want to do is every time you see the kid, you want to just check in that non-judgmental way and say, let's do our calendar. All right, how'd it go this week? And you go, okay, it's February 4th, February 3rd, 2nd. You do the same thing, and you come back through this day, since you started here, through the day you saw them last. And if it's 2 weeks before you see them, you can do it. In fact, this is valid for actually a timeline follow back to 90 days. So, but do it during treatment, because here's the opportunity. If the kid's you go back through this weekend and he didn't drink at all on Saturday, it's like, whoa, you can notice like, wow, your usual pattern is drinking on Saturday, and you didn't have anything last Saturday. No, I went to the movies with Joan and Sally. They don't drink instead of going to the keg party. Congratulations. They chose an alternative activity to using drugs that might have been a focus of treatment. So that's a very quick tour through the timeline follow back, but you can see how useful it is. If they continue to use or even escalate their use during your brief intervention time, that tells you something. That tells you like, wow, this is not cutting it. The brief intervention is not going to be enough for this kid. And here's the way I like to do a DSM checklist is make it one sheet. And I'm sorry, it kind of got cut off down here, but basically, look, there are 11 symptoms to DSM substance diagnoses, all substance diagnoses, the same 11 symptoms. And you can put all the different substances at the top. All right, so nicotine, alcohol, cannabis, sedative. Most of the kids are not using opioids, yes, but and other like over the counter. Some kids use triple C, of course, C and D, and blah blah blah. So you can probably you can modify this however you want, but this is lifetime you probably don't care about, but current use you do care about. So for all the substances they're currently using, okay, let's take the example we just had, alcohol, cannabis. You want to go through the criteria to see, do they meet criteria for mild, moderate, or severe? So, as you're going through it, it's like, so have you used, and for each drug, it might be different. So have you used in this is the criteria: recurrent use in physically hazardous situations. But you might have to explain that, like, you know, have you driven home when you're high? Or have you ridden in a car with somebody who was high? Okay, physically hazardous situations. Or you've, you know, buy your drugs in a park and it's kind of dangerous in that neighborhood, whatever it is. And you go, they go, oh yeah, I have. Okay, boom, check. Uh, Recurrent use resulting in failure to fulfill role obligations at school or home. You know, is the kid's truant at school now, in the parking lot using drugs or skipping classes, or, you know, the parents are complaining he doesn't ever do his chores anymore. I don't know what's happened to my kid. He doesn't seem to care about anything. Recurrent use, continued use despite social or interpersonal consequences. Yeah, my girlfriend broke up with me because whatever, she didn't like how much I was smoking. Check. So they give you examples of in their life of how they meet criteria. And so note that, because that's important for the personal feedback report if you use it. Do you have to use more and more? Have you seen yourself escalate use? You know, now I use concentrates. Smoking a blunt used to be enough for me, but now I have to use more and more, or higher potency stuff to get the same effect. That's evidence of tolerance. Have they experienced withdrawal? And you can find on the NIDA website, if you don't know what the withdrawal symptoms are of cannabis, only about 35% of kids have a withdrawal symptom. But if they can't get it, or if they're incarcerated, or if something happens, they can't, they will experience withdrawal. And, you know, it peaks at about 2 days and it takes about a week and a half, 2 weeks for it to go away. And it's uncomfortable. And it's a risk time for relapse. So have they experienced it, withdrawal symptoms? And have they taken, you know, I meant to go to the party and just have like 2 or 3 drinks, but I ended up blacking out, or I ended up, you know, getting really drunk and getting sick. So they use more than they plan to use, taking larger amounts over a longer time than intended. Persistent desire, unsuccessful in cutting down. I tried to cut, I couldn't do it. Spending more and more time using, recovering from the effects, obtaining it, trying to get money to buy it, all of these things. So basically, you've given up important recreational activity. I used to like football, but I really don't care about it anymore. You've given up important social activities, or a job, or whatever it is, to use. And cravings and strong desires, continued use despite physical or psychological consequences. You go through the symptoms. If they have 2 to 3, it's it's mild for cannabis use disorder. If that's the one that you just add up the symptoms, 2 to 3 is mild, 3 to 4 is moderate, 6 or more is severe. That's it. And you do the same thing for nicotine vaping, nicotine, alcohol, whatever they're using. But you should know, I mean, first of all, any kid who meets criteria for a substance use disorder could actually benefit from substance treatment, evidence-based substance treatment. In many cases, for the mild moderate SUD, in your hands, since you're trained in brief intervention, it's okay to try brief intervention, or maybe longer, or a few brief interventions. But if you're tracking their use and it's not changing, not going down, then that's a reason to refer to treatment. So let me just quickly, let's see, I don't have I want to make sure, okay, 10 minutes. Okay, good. I just want to make sure that I'm kind of stay on track here. So what do I mean by personal feedback? That, you know, and most people don't do this, but I think it is important. The way we set up a personal feedback is I actually fill out the sheet for the kid and I hand it to him and we go over it together, and kind of setting it up like, hey, this session is to help us both understand, and you compare how your drug or alcohol use stacks up compared to other people your age. Okay. Sometimes we have the idea that that everybody uses the same amount that I do, but that's often because we're hanging out with people who do what we do. And so if it's all right with you, I'd like to give you some feedback around, and you know, what other students your age, and you can get this from Colorado specific data, or you can get it from Monitoring the Future national data. And I'll show you where that resource is in a moment. But, you know, you give this information, you give the personal feedback. It's like, you know, you told me, let's see, you're a senior now, you're in 12th grade, and you use daily, and only about 6% or 1 out of 17 seniors across the country use that much. And they might say, well, that doesn't seem right. Oh my, no, everybody I know uses this much. Well, maybe that's other states, but in Colorado, I mean, here in Colorado, come on, it's legal. Well, it's not legal for adolescents, but you can go to Healthy Kids Colorado and find out what it is in Colorado. But basically you want to give them feedback, like of kids my age, 10th grade, 12th grade, 8th grade, what are other kids nationally in my age group, my grade level using? And you give the feedback for marijuana, alcohol, nicotine, tobacco, or e-cigs, whatever they're using. You put their use and their frequency of use in the context of what most kids their age are doing. And then they've endorsed, you've already gone through DSM criteria. Well, what are those criteria? Those criteria are really negative consequences of use, right? So you go, and let me just get this right. I mean, make sure, I think you told me when you came in that, let's see, you have used in physically hazardous situations, and that and then whatever you can do to make it more personal. I think you said at least 3 or 4 times you've either driven home yourself or ridden with somebody who was high or intoxicated. Okay, so that's a negative consequence of their cannabis or alcohol use. That you often miss school on Monday morning, or you're late to school on Monday because you're hungover from the weekend. Persistent use, whatever you can do to, these are the DSM criteria, but make it personal to what they told you, because after all, those are negative consequence. All of this is in the service of like, okay, wow, a reality check. Like you could ask a kid, don't you think you have a problem with drugs? You've had a DUI, you've had this or that. That's not consistent with motivational interviewing, and you will never get, yeah, you're right. You have to be more strategic and sophisticated and use MI. So you elicited negative consequences of use. They told you they met criteria, and you're putting their use in perspective here. You give them a chance to respond however they respond, but it makes an impact. Personal feedback, but personal feedback report is a really good segue into the next thing, which is goal setting. But let me first stop and kind of go back to what I referred to a minute ago, and that is the Monitoring the Future report. I mean, you could just go Google Monitoring the Future, and every year it comes out. It's sponsored by the National Institute on Drug Abuse, and it's 8th graders, a nationally representative sample of 8th, 10th, 12th graders. So, and every year you can see what are the trends in marijuana vaping, near daily vaping of marijuana. So that trend has gone down. It's 3.5% of seniors. It's gone down to 2.5%. Now that doesn't mean only 2.5% are using marijuana daily. It just says that's how many are vaping daily. But you can put their use, this is in the past year, to almost actually, more than 20% of high school seniors, about 20% of 10th graders, and about 8.1% of 8th graders. You can put their use in context. So of all kids your age and your grade, this is where your use sits. Past year marijuana, binge drinking, defined as 5 or more drinks in one, kind of session of drinking in a row in the past 2 weeks. So that's that's a lot of kids, 16.8, about 17% of high school seniors have had at least one episode of binge drinking in the past 2 weeks before the survey. And that was the kids, they were the kids who were in school that day. So past year out. So you all of these things are, boom, readily available to you. You just put it in the personal feedback report. It can be an important tool. So I mentioned that that's a good segue, that personal feedback, to goal setting. And I don't know, if you're going to do an intervention, if you're going to do something, you ought to set some goals for that. And the kid's going to set his own goals. And for us in our treatment program, we don't make all the goals related to their substance. It can be something else. I want a better relationship with my parents. I want to have a wider circle of friends. I want to make more friends, blah, blah, blah. But one of those goals, and I don't set a lot of goals. 3 is the max. Otherwise it gets overwhelming. And then one of those goals needs to be substance related. It's like, so if the kid goes, I told you, lady, I don't want to cut down I'm not interested in stopping or cutting down my marijuana use. Like it's a herb, it's natural. It's like, not a problem. I mean, if that's where the kid is, that's where the kid is, okay? But you could still say, even if they're not interested at all in cutting down their use, or they don't see it as a problem, could we agree that one of the things we could do is give you, kind of get more information about what marijuana's effects, the research on effects on the brain, adolescent brain development. Because after all, the more accurate information you have, that informs, you can make good decisions for yourself. Yeah, okay, well, that'd be okay. Even if they don't cut down, you can still focus a goal on substance related goal, no matter where they are. But to find out where they are, and then, you go through the goals, I would like to change this thing in my life, whatever it is. And then one is substance related. The reasons I want to make that change are, give me your 3 reasons why you would want to make that change. Okay. But you want to really operationalize this. What can I do right now to meet that goal? What could trip me up, interfere? Who could help? Does you have a support group who could help you achieve the goal? And what will be the first signs for us in tracking it to see if you're moving towards achieving that goal? It doesn't have to be the whole banana, but what are the interim milestones of progress we can track? Make it measurable. So do the worksheet, goal setting. Now, before you do goal setting, you might want to do the personal rulers to inform goal setting. So for example, if you can't get the kid to set a substance related goal, before I would build this out, I would say, I just need to really get where you are with your substance use and other things, substance use. And so let's say this kid only uses marijuana, just to keep it simple, because they have the rulers will be different for each substance, but let's just keep it simple with marijuana. So, but you're strategic about this. So let me understand, this is in the service of understanding exactly where you are with your current level. So how important is it for you to change your current level of marijuana use from 0, not important at all, to extremely important? And even the most oppositional kids usually don't say, I said it's a 0. It's like, how important is it for you to change your current level or reduce your level of marijuana use? Even if they're down here, like, I don't know, I'd say a 2. You can respond strategically. Now you want to respond in a way that gives them an opportunity to give you problems or why it's important, not why it's not important. So in other words, if he says 2, I might say, why are you not a 0 or a 1? Then he has to give me reasons why it is important. If I don't, why isn't it a 7 or 8? My God, you've got a DUI, but then he has to give me reasons why it's not important. You see what I mean? Use MI, confidence ruler. Okay, it's at 45. So let me just move through this. How confident are you? If you decided to change your substance, how confident are you that you could do it? Well, I'm very confident. I mean, I'm 7. And you might respond, what gives you that confidence? You're building, well, I've quit before. I was able to do it. So you want to build on those strengths. What might trip you up? What gets it? Well, but then I did relapse. And how ready? So wherever they are here, how ready are you to do it now, to change your substance use now? That's important. Then you can go back to goal setting. So let me get through this last. If you can't get anything for substance use goals, you can go through the happiness scale, like how happy or unhappy are you with your current level of marijuana use? Whatever they say, you work it the same way. That is, if you're pretty happy, 8, why are you not a 9 or a 10? Well, I'm not that happy with it because, and then you go through the same exercise with all these other domains of their life. And I can tell you for sure, there are other domains of their life that are important to them, relationship with parents, friends, school performance, other things that the drug use is impacting. So you're trying to work for a discrepancy between their values and things that are important to them and their current level of use. So you can go through this, and sometimes that nudges them into a readiness, a higher level of readiness. Okay. Functional analysis, I'm going to only just barely touch the surface of, because I want to stop in 2 minutes. So we have at least 10 minutes for questions. And that is, you know what they use, what are you using, and whatever, who are you usually with? What do you like about the drugs you use? What are your positive expectancies? What's the downside, the negative consequences? And then I move to, what are your triggers, external triggers? Like who are people, places, and things. The things they paired a million times with drug use become conditioned stimuli, just like the steak and the bell for Pavlov's dog. The steak will cause the dog to salivate, but if you pair the steak with a bell every time, pretty soon you ring the bell and that causes the dog to salivate. That's what drugs do. If you're always scoring your drugs in the park, a certain park, if you walk through that park, your dopamine shoots up before you ever touch a drug, and you're like 8, 9 craving, you can't make a good decision when you're activated. You could make a good decision when you're 2 or 3, you're still at home and you decide not to walk through that park. But until you understand your external and internal triggers, you don't even know what they are. Internal triggers are things like, I usually use when I'm bored or when I feel bummed out or whatever, paying attention to if I'm anxious, bored, depressed, whatever so you work through this so that this informs that you couldn't give it up. If you were going to be able to cut down, we would have to give you some other skills to manage the anxiety so you don't have to automatically use, you see, strategically. So let me just go, how do you make the ERT work? When is brief intervention not enough? When do you refer to substance treatment? And if you do, how do you make that work? Increase the chances. So you know that you can try brief intervention, but all adolescents who have a substance use disorder, certainly moderate to severe, should probably be referred for substance treatment. But you know what happens if you do that. Hey, your screening results indicate you might have a substance use disorder. I'm going to refer you to treatment. Are you interested? No. That's just not going to ever work. It's only 10%, less than 10% of kids, it's still true in 2021, who could benefit from substance treatment receive it. So what we've done, what we've started, and it seems to be working, is our SBIRE approach. Don't refer, for God's sake, don't refer for substance treatment. The answer is no. But if you refer for a brief consultation evaluation, the kids are usually going to say yes. So I'm going to give you a way, you can refer to me, or you can try to make this arrangement with substance treatment programs in your area so that you can refer for a brief consultation or evaluation, not treatment. So thanks for being so open about your use of marijuana and alcohol. It sure sounds like there's some benefits. Or in your case, we've tried a couple of brief interventions and we're not making a dent in this use. And I'm concerned about the frequency of your use. And plus you've stopped doing a lot of things, football, other things. Your life is in a small box now with marijuana use. So if it's all right with you, I'd like to refer you for a brief confidential eval with an expert in this area. Would it be okay if I share your screening results with Dr. Riggs? Have her give you a quick call. It takes about 15, 20 minutes. And I've been doing this since October with pediatricians and with mental health clinicians and whatever. Using MI, I'm getting 70% of the kids are engaging in substance treatment, 70%. It's less, you know what it is. It's way less than 5% with ERT, referral to treatment. And we're getting about 70% overall of those eligible kids to engage in treatment, in substance treatment using this approach. And you should know what the evidence-based treatments are for substance use disorder. They're on this side of family-based interventions and cognitive behavioral therapy. But for cannabis use disorder, the number one is MET CBT plus contingency management. And that's what we do. That's what I do in our treatment. It's fully integrated mental health substance treatment, but it's MET CBT plus contingency motivational incentives. And you should know about this new resource guide just published in February. SAMHSA put out the treatment considerations for kids who have, and young adults who have serious emotional disturbance or mental illness and co-occurring substance, and the resources. And I'm proud to say our treatment Encompass is there, is also listed and featured in the SAMHSA resource guide. So I'll stop there, but if any of you don't have the resources for substance treatment in your backyard or whatever, you are welcome to call me or send me a secure email, and I will, we provide this via telehealth anywhere in the state. So I'm inviting you to do that. So thank you for your attention, and I'll stop there and take some questions. I hope that hit some right notes. It was a fast ride, I know. And I hope you'll give some of these tools a try, because you're already trained clinicians, you know what to do. I hope that some of these tools will be useful for you in your brief intervention.
Any questions? Thank you so much, Dr. Riggs. This has been amazing and so helpful.
Gina, I'll let you vet I haven't been monitoring the chat. So if people want to speak up or unmute and ask the question, great. But since there's so many on the call, you might want to just be the person who says, here's a question. So.
Yes, I will scan the chat box, but yeah, in the meantime, feel free to unmute if you have any questions.
Is this useful to you guys at all? I mean, do you think any of this will be like, wow, okay, thanks, but no. I hope it was helpful.
So we have one question. Okay, the questions are coming in. One question is, how soon after the referral do you reach out to the student?
Oh, to find out what happens? Well, if you do the Aspire model like to Encompass, I always give the feedback to the provider. It's like, okay, so Sam, would it be all right if Dr. Briggs gives you a call and does this brief consultation? And so, what I do is I let the provider or the the person who referred the kid, hey, this is what happened. Johnny said yes or no. And then he might say yes to me, but not show for that intake appointment. And then I get back to the clinician and say, the next time you see Johnny, you might give him a nudge. He's kind of on the fence still. And so you might give him a nudge. Or if he said yes, and now he's enrolled in Encompass, you can get back to the kid anytime you want to and say, how's that going? And whatever, because this kid's coming back to you regardless. And let's say he does well in treatment and he comes back to you, you want to be able to support his recovery and support if there's a big period of stress coming up or finals or whatever, that's a time where he could slip or have a lapse. And you want to say, what do we need to do to protect you from going back down the rabbit hole all the way? So, I mean, I communicate with providers. It's fair for you to, whoever you're referring to ask for that feedback for that. You deserve, I referred a patient to you, that's like a black hole. I mean, you should be able to know what happened and not just have to ask Johnny, but the provider you referred to should get back to you and say, he's in treatment or he's not.
Dr. Riggs, this is Carolyn. I was actually wondering how soon you usually reach out after this referral happens. Does it happen like in the next couple of days usually, just for informing the student?
Sure. Wait, so you mean, so you talked to Johnny about referring him, and is it all right if Dr. Riggs gives you a call for this, or if somebody, did he engage in whatever you asked him to engage in? Well, I mean, for example, I can give you just my experience. If you refer a kid and I'm supposed to reach out to the kid, if I can't reach the kid in like 3 or 4 days, so within a week, something should have happened.
Okay, so it happens quite fast, within a couple of days.
Well, yeah, I mean, there are some treatment programs that have a wait list, like, oh my God, it'll be 2 months before we can see him. We'll rip it with that I mean,
yeah.
So about a week is what you should I think what we should expect. Something happens, or he's got an appointment lined up within a week. Somebody reached out or did something in about a week or two. 2 would be the outside, because you don't want this to go on and on forever.
Thank you.
My parameter.
Thank you. One other question we had is, oops, I lost it, sorry.
Oh,
Is the
Maureen,
best way to refer patients to you via secure email?
yes, that's I mean, the best way is, and it's HIPAA compliant. If you just write secure in the subject line of the email, that's supposed to come in and be secure. So you can give me, I have a 17-year-old, blah, blah, blah. And what I need, if you want to start referring to me, I will give you an Encompass referral for. So all you have to, I need a date of birth. We prefer Medicaid cover kids. So it's free to them. But basically I need a date of birth. Are they covered by Medicaid or something else? And why you're referring. He's, marijuana use every day, blah, blah, blah. And it's okay to give parent contact information, but I need the kid's cell. I always reach out to the kid first to get their buy-in and not blow their confidentiality. So if you want to, secure email is the way to do that. Yep, that's how you do it.
Thank you. And just so you all know, Dr. Riggs, we can touch base after this, but I can send out, concrete instructions along with the brochure, just so that you all have that, if that's helpful. And then we just had one more question. Could you share a little bit, I know we only have a couple minutes, but could you share a little more about how treatment works for the adolescent? For example, like the provider of treatment, the individual sessions, like, number of them and frequency.
Sure.
And how are co-occurring disorders addressed? I know that's a lot in one, but.
Yeah. Well, I mean, I can only speak for my treatment. I do know, I do know the other evidence-based treatments or in the family-based interventions, but if you're asking about, NIDA, SAMHSA, and a Cochrane meta-analysis all converge and say the most effective treatment we currently have for cannabis use disorder, and that's what your kids have for sure, is MET-CBT, motivational enhancement plus cognitive behavioral therapy plus contingency management, which usually means you positively reinforce in an escalating scale negative urines. Okay, we do that. We do it telehealth. We spin the prize wheel, and whatever they get, we send them an Amazon card for that. Okay, so basically it's once a week cognitive behavioral therapy, weekly outpatient. And you might think, whoa, that's not very much, but they need a life to practice the skills in. And you'd be shocked how severe these kids are walking through the door. They do really great. It's 17 sessions. So this is a piece of work. It's 4 months of individual once a week, about an hour a week. We deliver via telehealth. We use motivational enhancement, motivational interviewing throughout. You can't talk to adolescents without knowing MI. And we do the motivation engagement, the rulers, and personal feedback, goal setting, functional analysis. Then we start skills modules, coping with cravings. And so how do we integrate treatment? When we go through functional analysis and you have the internal and external triggers, that's the gold of treatment. That informs how we then individually tailor this treatment for this kid. For example, if he says, when I get depressed or bummed out, or I have co-occurring depression, whatever, that's a trigger for my use. That means after I get through the first 4 modules, I'm going to bring forward, there's a menu of modules, skills. What I'm going to bring forward next, regulating negative mood states. That's what's relevant to this kid. He's got to have other ways of managing these negative mood states other than just using. So I know that if it's anxiety or if I get so stressed out, I'm going to bring forward the modules, stress management, coping with, stress. I need to give him the specific skills that address his triggers for use, which amplify the tools in the tool bag to deal with that so he doesn't have to use. So that's how it works. And if their symptoms of co-occurring depression, anxiety, ADHD, whatever, are not coming down at the end of the first month of treatment, I've conducted most of the clinical trials that exist on medications that are safe and effective in kids who still are not yet abstinent as long as they're in treatment. So we get a med-eval. So we make sure that we track does the depression symptom come down or their co-occurring psychiatric symptoms come down during treatment? We owe it to kids to measure treatment response. That's how we do it. We repeat measures to measure, do the symptoms you walk through the door with and your substance use you walk coming down during treatment. If not, we do something different. That was a fast answer to what treatment, but that's kind of it.
Thank you. That was super helpful. Well, I know it's a couple minutes after 1, but I just wanted to say, thank you all so much for joining today. Thank you, Dr. Riggs. This was so helpful, and we'll be sure to send a ton of follow-up resources to you all. In the meantime, feel free to email myself if you have any questions, or Dr. Riggs, or I can connect you directly. And if you could also just complete the following post survey in the chat box, that would be wonderful. And Dr. Riggs, I'm fine with staying on a couple minutes extra if you want to. But in the meantime, for those who have to jump off, we hope you have a great rest of your day.
Well, I do too, but let me just say one thing before everybody jumps off. And
Sorry.
that is, what I can do, Gina, is I can send you kind of the information I would need in that secure email, like, to be able to reach out to the kid. So I can send you whatever, the Encompass referral form. It's just very brief, boom, boom, boom. You can either put it in the email or you can attach it in the secure email. I'll send that to you so people they don't have to go back and forth. How do you do that again? And so that you have that just facile, whoever's interested in referring a kid. So I can do that and send the materials. Please feel free to reach out. And it was a pleasure. Thanks for your attention today. Okay, guys.
Thank you so much.
Yeah, you're welcome.
That sounds great.
All righty. Thank you.